I think this has been a fascinating discussion so far, but I think it's a discussion where we've actually replicated a lot of the terminological confusion around this word innovation. And this isn't just a semantic problem, because it is a real issue for how we think about innovation in healthcare. I wanted to start by saying, being perhaps a bit provocative, but I think technological innovation in healthcare is a double-edged sword, as we say in English. It's good and it's bad. It's good, we all want it, we need it for all the reasons we've heard this morning about the need to address an aging population and deliver better quality healthcare for all. But it's also a problem, I think, and it's a problem for taxpayers and for governments, policymakers, because it drives up cost. The more we innovate, the better we get at delivering new drugs, new medical devices, new medical technologies, the more expensive it becomes, healthcare becomes. And that's because it allows us to do new things, treat more people, pick up conditions that previously weren't detected, which we then have to address. So innovation is a good thing. We all know we need it, and that's why we're here today. But it isn't an easy thing to manage in an economy and society. And I think that's where the disruptive innovation, radical innovation distinction actually becomes rather important. And I was very pleased to hear Monsieur Colomb this morning. In his speech, he mentioned Clayton Christensen, which is where that concept actually came from. But unfortunately, it's become much more loosely defined, and defined as any kind of innovation is essentially a break from the past. A break from the past that allows us to radically drive up the performance of a product or technology. That's not what disruptive innovation was defined as originally. For Christensen and others who've come to write about this subsequently, it's really all about moving away from very high cost, high tech, possibly over-specified models of services or products towards versions that are simpler and cheaper but good enough for people. And we've seen this in developing countries where the $3,000 car, for example, in India is designed to increase the market for the automobile by producing a cheaper, simpler version. In healthcare, in medical devices, there are many examples, but for example, the GE ECG scanner, which is substantially cheaper than what we purchase here in Europe or North America, but is good enough. So I think that distinction between the radical innovations, that partly what we've talked about this morning, where we're harnessing the power of biology, of data analytics, dramatically improving the performance of drugs is one thing. But that is different from, I think, the models of disruptive innovation, which are now beginning to be developed and applied in healthcare services in the UK, in the US, and elsewhere, where it's all about driving care away from these very, very high-cost, high-tech models delivered in expensive hospitals by highly paid consultants, down the chain into the community, into self-care even, supported by technology, yes. And the real question here, I think, is where does the biopharma industry sit within that emerging disruptive innovation model in healthcare? It's a little bit more difficult to apply that cheaper, simpler, but good enough model in biopharma, I think. A cheaper, good enough pill doesn't quite cut it with regulators and payers and the public. But I think there are perhaps two ways in which that sort of Christensen type approach to disruptive innovation does apply in biopharma. The first is what we've been hearing about in the last 20 minutes or so, which is really all about reducing the cost of the development process through open innovation, collaborative relationships, pharma companies funding and supporting small biotech companies, harnessing the power of social networking, patients themselves, and big data and so on. So that's the first area, I think, where you perhaps can start to apply some of these disruptive concepts, because it's all about delivering drugs, but doing it in a cheaper, more effective way. The second, I think, is more challenging, actually, and I don't have an answer to this, but really it's how do biopharma companies sit within that emerging, disrupted healthcare system model that's beginning to develop in some countries. In other words, how do they reinvent themselves, not just as providers of ever more beneficial and expensive pills, but as part of that healthcare system value chain, perhaps monitoring patients, providing a whole range of different services wrapped around that drug.
And this is what I actually
so I
wanted
think, that's the difficult question for me. That's the real disruption.
A couple examples for you. I think we already discussed the iPhone in itself is not disruptive because it's more expensive and created a market that increased the cost. But when you start applying the iPhone, connecting patients to doctors so that you avoid a visit or you avoid getting into a hospital, that becomes disruptive, right?
Yes, and I mean, ultimately, it's what we should be focusing on really is avoiding the need for people to take these expensive pills,
and also
by better prevention and intervening earlier.